Welcome to the Brain Health Hookup. I'm Laurel Myers-Hurst, your resident groovologist, and I believe that better mental health needs to be fun. Here we talk about mental wellness, we explore the physical, emotional, and relational needs we have as humans with the science and practices that help our mental health to flourish. Plus, we dive into my signature method, groove therapy, that engages folks in groove-based music making to lift mood and lower inflammation and pain. I'm so glad you're here. So let's hit it. Well. That's a deep subject. With up to 1 in 5 Americans taking antidepressant medications, it's really important to know what situations call for antidepressants and evidence-backed ways of helping people toward remission. This is a big discussion today with very detailed medical explanations, scientific information. And I just want to remind you every time you hear this podcast that I am a psychiatric nurse practitioner, but I'm not your psychiatric nurse practitioner. Everything we say here is the things I tell my own patients, and you need to inform yourself to have these discussions with your prescribing provider, whoever checks on your general welfare, your physical health, your mental state of being. So I'm not your nurse practitioner, and I don't want you to mistake anything I say for direct care for your situation. That said, there's so much we can talk about when it comes to care for depression and mood problems that you can apply when you fact check what I have to say, look at it for your individual situation, talk to your care provider, and take action. These are actionable steps we're going to talk about today. So, first problem I see in the broader problem of high rates of prescribing for antidepressants are the conflation, meaning bringing two things together, the conflation of distress and depression. So emotional distress is due to an identifiable stressor. So when you can look at something in your life and say, it's more than I can handle. It's overwhelming. There is so much there. I can barely chunk it up and digest it, right? It's very difficult to process. It's a very heavy season. This is emotional distress. So distress can be very long enduring. Sometimes that's because the circumstances around you haven't changed. Maybe you have a situation with a very volatile romantic partner or a past traumatic wound that you carry with you, and the distress from that is a burden that's too much for you to bear. This is distress and not necessarily depression. Depression is a more than 2-week period of very low mood, maybe thoughts of self-harm or even death by self-harm. They include sleep disturbances, feelings like you're not even interested in the things you would normally be interested in, feelings of guilt, like you've let yourself or someone else down, worthlessness that might go with that, a sense of no energy. You cannot pick yourself up and move yourself. Also, focus and concentration problems, appetite changes, moving so fast or so slow that other people notice they must be depressed. And then the severity of that is what we're looking at. In cases of depression, this is often a set of symptoms we see when there is no evident cause of distress. So there may be no identifiable external factor at the moment that's causing that symptom set, and it's there nonetheless. I often hear patients saying things when they have true depression like, I shouldn't feel this bad. There's no explaining why I feel this bad. We'll talk in another episode about the whole should word and when we can and can't use it to our benefit. But generally speaking, again, patients who are in true depression say things like, can't account for why I feel this badly. I should be able to snap out of this. Going back to the movie Moonstruck and Cher, one of Cher's most powerful scenes in a comedic drama were when her romantic partner was sharing the many, many distresses of their personal circumstances. And Cher appears to be empathizing. She appears to be locked in on all her partner's needs and really reading his distress. And then suddenly she turns and slaps him in the face and says, snap out of it. Snap out of it. That does not work, right? That doesn't work for you. That doesn't work for me. You would never want that kind of treatment from a primary care provider, a psychiatric care provider. You want someone who can look at what you're going through and truly understand not just what the surface looks like, but what might be the root causes of that, and then address those causes to bring you forward toward remission, right? So I just want to reiterate again, there's a huge difference between distress, which is related to external factors we can point our fingers toward. We can put our finger on it. And depression, which tends to be much more ambiguous, like, I don't think I really would be feeling this way if I were healthy. Something is unhealthy about me right now. And that's the symptoms of depression, like I mentioned before. So in these circumstances, when do antidepressants help? Antidepressants are much more helpful for depression than for distress. In the cases of distress, we kind of have two options. One, either radical acceptance, as in, if this never changes, I choose to be okay, or escape, meaning sometimes the circumstances have to change. We have to change the atmosphere and environment, or distress will continue to affect us. So those two things, I equally advocate for both of them on different circumstances, but in the cases of distress, that's what we're looking at. Antidepressants help more in the case of depression, where there aren't things we can point our finger toward, but we have these physical symptoms of what I said before is sick syndrome. Our brain has decided it's not safe to grow and change and reach out and connect right now. I need to shrink. I need to retract. I need to go into a shell until circumstances are more advantageous and I can flourish again. Antidepressants, even in that latter case, are only effective for the first 6 months of treatment in most all the studies that have been done. So antidepressants, the bar for them coming to market is quite low, meaning that they only have to beat placebo or a dummy pill. Antidepressants can come to market if in 3 trials where people don't know whether they're getting the dummy pill or placebo, or they're getting the antidepressant, the proposed antidepressant. People don't know which one they're getting, and the antidepressant beats the dummy pill. You can see that is a pretty low bar. And in truth, those antidepressants that beat the bar do help speed people toward recovery within the first 6 months. So in cases of moderate to severe depression, antidepressants are indicated because they can give a boost for people who are in severe symptom state to get better faster and to feel more like themselves faster. After the 6-month mark or so, whether we gave you a dummy pill or antidepressant, it would be about the same. So antidepressants can speed toward recovery, but not make the difference in whether you will or will not recover from depression, even moderate to severe. Now, for moderate to mild or even nominal depression, medication is not indicated. I can't make that more emphatic than that. In the states of mild depression and less, antidepressants are not indicated. When you go to your primary care provider, this is especially important because we're often seeing a primary care physician for mild depression. So it's good to get early treatment in the case of mild depression. Absolutely. The earlier we catch depression, the more likely we are to go into remission. So talking to your provider about depression earlier rather than later when all else has failed is definitely a benefit. And in response, as far as the evidence shows, your primary care provider is best if they recommend psychotherapy. Why? If you were with me in episode 5, we talked extensively about neuroplasticity and the current conversation around old theories of mood problems and emerging and recently confirmed theories of mood problems. That is that it's the connectivity in your brain, the rate at which your nerves refresh themselves that may be the actual cause of ongoing mood problems well after your distress has ended, right? So neuroplasticity is increased and directed by psychotherapy. It's very helpful. And psychotherapy has been placed head to head with medication. You already know I put a lot of stock into changing the connectivity of the working of your brain with psychotherapy, but why? It's because in head to head trials, psychotherapy is as effective as antidepressants in mild, low level, moderate depression, as effective. So rather than going with what may be an outdated theory of monoamine cause, meaning brain chemical imbalances of serotonin, dopamine, and noradrenaline, using medications that modulate or hijack the way your brain uses those monoamine transmitters, especially serotonin, we can get as much benefit toward remission with psychotherapy. Okay, so let's talk a little bit more about psychotherapy. If it's so effective, you got to know what you're getting though, right? It's got to be effective. So I usually think of psychotherapy in 3 buckets. Right here, the first bucket is supportive psychotherapy. I provide this for all of my patients, even when they're coming for medication management. I'm empathizing, I'm affirming, I'm encouraging them to consider themselves with positive regard. I'm like a paid best friend. That's what supportive therapy is. If someone's good at supportive therapy, they're sprinkling that through all the care they give, whether they're a psychotherapist talking to you for an hour or a primary care physician talking to you for 10 minutes or a psychiatric care provider talking to you for half an hour or 45 minutes. We're all using supportive therapy. If we're good at our job, we ask you for permission before we give advice. And we're there as a sounding board while you process the things that you need to talk about that you can often work out for yourself when you have someone who can hold that space for you. That's supportive psychotherapy. Then there's a huge bucket in the middle of cognitive behavioral therapies. Cognitive behavioral therapies challenge the ways we might twist things up in our mind to make them more painful than they would normally have to be. So we have a habit, just normal negative bias in human thinking. We have a habit of taking things that are neutral and turning them to the negative, and sometimes even taking things that are positive and turning them to the negative. So in fact, day in and day out, a lot of things seem negative. Those are things we have just grown into. It's our way of being in the world. We didn't intend to get that way, but through the experiences we had, the models that we experienced in our parents and other people, that's our default when we get to adulthood. And when we are adults, we can design the ways we think. We can challenge negative thoughts. We can replace them with positive or more realistic thoughts. And we can learn to listen and accept feedback and incorporate that feedback by our choice to become the people who we want to be. All of those therapies are in the realm of cognitive behavioral therapies. Now, the one thing that cognitive behavioral therapies aren't really good for, remember I said if we're taking neutral things and making them negative, or taking positive things and making them negative, cognitive behavioral therapies are not so good at the things that are truly negative, like things that have hurt us in the past. That is the realm of trauma therapies. There are several different trauma therapies, and they all focus on pulling off the side of the road, cleaning the wounds of the past, opening them up to healing, and then tending to that healing until it's complete, or at least until it's farther along. Most of those therapies, in some way or another, take the needs of where you feel that woundedness in your body. So it's the feeling of gut-wrenching pain that you feel. It may be literally tingling or numbness in your body. You may feel like you space out when certain things happen, or like you're reliving the past. Those are all signs that you have wounds that are affecting the present, and we need to use trauma-focused therapies to address them. You might even think if someone tries to pull cognitive behavioral therapy on you when you're wounded, you might be thinking, okay, I'm not distorted in my thinking about this. I am really hurt, right? It almost seems offensive that they try to fix you with changing your thinking or positive thinking. Like, no positive thinking is going to undo the wrong that has been done to you. It's a wrong that may be in the past, but it still needs tending to. It needs cleaning. It needs attention. It needs care until healing can be affected. So those are the three buckets. Supportive therapy, we almost always do that. Cognitive behavioral therapy, I call it adult 2.0. It's you deciding to be your best you. It can be usually accomplished in a short series of very richly educational appointments, like 10 to 16 sessions. Therapy work, it depends on the route you go. When you use your body to heal your body and your mind, it doesn't have to take forever. It doesn't have to look like spilling your whole trauma map and every detail of the grotesque things sometimes that have happened to you out on the table. Sometimes we can use your body to heal the body and the mind by things you may have heard of, like somatic experiencing, eye movement desensitization and reprocessing, called EMDR, or other somatic therapies that are very gentle and tolerable and don't re-traumatize you by bringing all of those things to light. So you can see how distress versus depression are two different things. Distress in the present needs one completely different set of remedies than depression that lasts after the distress has been relieved. And then there are several ways of dealing with the long-term consequences of distress, including having the right support, having mental habits that don't hurt you more than you need to be hurt, and then directly dealing with the hurts that have come into your life. I hope this helps you understand what effective therapy looks like. If you feel like you need more support in cognitive ways and in trauma responsive ways, and you're only getting supportive therapy at this time, maybe it's time to take a brief tour through some of these other types of therapies and then go back to your therapist who has been helpful, or ask your therapist if they could go deeper into some of these other very intentional ways of supporting you if they have that ability and education. I don't want you to waste your time. I don't want you to waste one more month, one more year feeling the weight of what you have had to bear to this point. You deserve to flourish. I believe that with all of my heart. And I hope this information helped move you toward flourishing in some way today. I'd love to hear how you have been affected by this information today. As always, I'm open to challenges and comments. Please do contact me at the website in the show notes. I appreciate you so much for listening. Thank you for tuning into this episode of the Brain Health Hookup. I hope this episode radiates with the conviction that generating mental wellness needs to be fun and safe. We want you to find your power and understand your innate design to flourish in everything you do. And we hope that inspires you to come back and listen for more. I'd love for you to leave a review of this podcast, as it helps this show grow to reach more people who need to make mental wellness fun. You can find the leave a review button, as well as all the YouTube visuals, bonuses, and ways we can help to support you on our website, podcast.grooveforhealth.com. I appreciate you more than words can say. See you next time, and remember, together we have everything we need.